Welcome back to the Deep Dive. Today we're doing something a little different. We are putting away the casual curiosity. We are shifting gears entirely.
We are going into the trenches.
That's right. Specifically, we're simulating the pressure cooker of an MD anesthesiology final exam. We've got the essential texts here in front of us. We're talking Miller's Anesthesia, Morgan and Mikhail, Guyton's Physiology.
And crucially, the specific exam guidelines for Gujarat University.
Exactly. And the mission today is very, very specific. We aren't just trying to, understand pain. We are constructing the perfect distinction-level answer for that dreaded 20-mark theory question.
The one that always comes up. Describe pain pathways and pain modulation.
So for this session, I'll be playing the role of the exhausted third-year resident. I've got the caffeine shakes, the exam is in 2 weeks, and I need to get this information out of the textbook and into a structure that actually scores marks.
And I'll be the senior faculty. My job is to stop you from rambling, to force you to be precise, and to point out exactly where the external examiner is waiting with a trap to fail you.
Okay, I'm ready. Let's start with the absolute nightmare scenario. I walk into the Viva Voce. The examiner looks over his glasses, stone-faced, and just says, "Define pain."
It's the classic trap. It sounds so simple, but it's designed to see if you're thinking like a postgraduate.
Right.
If you say something like, pain is a feeling when you get hurt, you have arguably failed that station before you've even begun.
Wow. Okay.
In a postgraduate exam, definitions have to be definitive. You need the IASP definition, verbatim.
The International Association for the Study of Pain.
Mm-hmm.
Got this on a flashcard that is practically worn down to a nub.
Good. Recite it for me now.
Okay. An unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage.
Perfect. Do not paraphrase that. Quote it. Now, the follow-up question is always to unpack it. Why did a committee of global experts fight over those specific words? What's the most important part of that sentence for a clinician?
I'd say the phrase emotional experience. That's the heavy lifter there, because it distinguishes pain from just a simple electrical signal. It implies that without the emotional processing, the suffering, the unpleasantness, it isn't truly pain.
Correct. And what about potential tissue damage? What does that cover?
That covers the protective reflex, right? If I touch a hot stove, I pull my hand away before I'm actually burned. That whole experience is still pain, even if the tissue technically remains intact.
Precisely. And the final clause described in terms of such damage, what does that account for?
That's for the patients who can really baffle us. Psychogenic pain, phantom limb pain.
Exactly. There's no injury we can see, no nociceptive input from the limb, but the patient describes it as if there is. To them, it is unequivocally pain, and that definition respects their experience.
This leads directly into the core distinction that Miller just hammers home, which is nociception versus pain.
This is the concept that separates the technicians from the clinicians. So explain it to me as if I were your examiner.
Okay. So nociception is the hardware aspect. It's the neurophysiological process. It's the transduction and transmission of a noxious stimulus from the periphery to the central nervous system. It's just electricity moving up a wire.
Can it happen without consciousness?
Yes, absolutely. Yeah. It can happen when a patient is under general anesthesia. You make an incision, and their heart rate goes up, their blood pressure spikes. That's nociception.
But it isn't pain.
No. Pain requires the cortex. It requires consciousness and interpretation. It's the subjective experience. As I think Morgan puts it, all nociception usually produces pain, but not all pain comes from nociception.
That's the money quote. Give me an example of pain without nociception.
Phantom limb pain is the perfect one. The patient has 0 nociceptors in their foot because, well, they have no foot. But they can experience excruciating pain in that foot.
So if you conflate these two terms in your exam answer, you look sloppy. It shows a lack of fundamental understanding.
Hey, definition secured. Now, for the long answer paper, I need a structure. I can't just write a wall of text.
Absolutely not. The examiner has a mental checklist. If you don't have clear headings, they literally can't give you the marks for those sections. Your first heading, right after the introduction and definition, must be classification.
This feels like, some free marks if I can just memorize it. We usually classify it in 2 main ways, right? Duration and mechanism.
Correct. Start with duration. But don't just write acute and chronic. Give me the physiological distinction. What's the purpose of acute pain?
Acute pain is protective. It has a clear biological purpose. It alerts the body to injury or disease. It's almost always nociceptive, and it triggers that whole neuroendocrine stress response, the fight-or-flight reaction. Tachycardia, hypertension.
It's an alarm bell. And chronic.
Chronic is where the textbooks start to argue a bit about the timeline. Some say 1 month, some say 6. Miller seems to settle on 3 months as a common cutoff.
But the timeline isn't the real definition, is it?
No, the real definition is that it persists beyond the normal expected time of healing.
And its biological value.
It has none. It's maladaptive. The alarm bell is still ringing, but the fire is out. It becomes the disease itself.
Very good. Now, the more clinically relevant classification for us, pathophysiology or mechanism, this is what dictates our drug choices.
Okay, so here we have nociceptive versus neuropathic. Nociceptive is the normal kind of pain. The system is working exactly as intended, just detecting actual or potential tissue damage.
And we subdivide that further.
Right, into somatic and visceral.
Drill down on somatic for me.
Somatic is the body wall. So skin, muscles, bones, joints. And even that has 2 flavors. If it's superficial like a paper cut or a pinprick, it's very sharp, it's well localized, you know exactly where it is.
And that's mediated by which fibers?
That's the fast A delta fiber territory.
Good. And the other type of somatic pain?
Deep somatic. That's from, say, a sprained ankle or fractured femur. It's that dull, aching, sickening pain. It's much less localized.
And that would be
C
there.
fiber territory, the slow pain fibers.
Excellent. Now what about visceral?
Visceral is pain from the internal organs. This is the weird one. The stimuli that trigger it are completely different. You can actually cut the bowel or burn it during surgery, and a conscious patient might feel nothing.
What?
But if you stretch it, if you cause ischemia or if there's inflammation, then it's agony.
And its character. How do patients describe it?
It's terrible. It's
Yeah.
diffuse, cramping, deep,
Huh.
and the localization is awful. They'll just wave their hand over their entire abdomen. And it often gets referred to other parts of the body.
We'll come back to the mechanism of referred pain. It's a classic exam question. Now, what's the other major category of pain by mechanism?
Neuropathic pain.
And what's the fundamental difference here?
Here, the wiring itself is broken. It's not
Yeah.
detecting damage anymore. The nerve itself is the source of the pain. It's caused by a lesion or a disease in the somatosensory nervous system.
Give me some classic examples.
Diabetic neuropathy, post-herpetic neuralgia after shingles, or even pain after a spinal cord injury.
And what are the key words patients use to describe this pain? What should set off alarm bells in your head?
Burning, shooting, stabbing, or like electrical shocks. It sounds different.
And why is this classification so critically important for us as anesthetists?
Because our standard toolkit often fails. Nociceptive pain, especially somatic pain, loves opioids. It responds really well. Neuropathic pain, it sort of laughs at morphine.
So what do you need?
You need a different class of drugs.
Yeah.
You're reaching for antidepressants like amitriptyline or anticonvulsants like gabapentin or pregabalin.
Perfect. You've set the stage brilliantly. Now you have to get technical. We're going to trace the signal from the point of injury all the way to the cortex. Section 3 of your answer, the nociceptors.
Right, the pain receptors. And it's important to remember, these aren't specialized little organs like Pacinian corpuscles for pressure, are they?
No, they're not. They are just free nerve endings, the raw, exposed wires of the nervous system. But they aren't all the same. Guyton gives a good classification based on what kind of stimulus gets them to fire.
Okay, so we have mechanoreceptors, which respond to intense pressure or a pinch.
That threshold, yes.
Then thermonoceptors for extremes of heat, usually over about 42 to 45 degrees Celsius or extreme cold.
And then the biggest group.
The polymodal nociceptors.
Tell me about them.
These are the workhorses, aren't they? They're mostly on the C fibers, and they respond to everything: mechanical stimuli, thermal stimuli, and most importantly, chemical stimuli.
The inflammatory soup, you must use that term.
Right, the inflammatory soup.
What's in it? When you damage tissue, cells rupture, what do they spill out?
They spill their guts. So you get potassium ions, protons, so hydrogen ions, making the area acidic ATP.
Good. Then the immune response kicks in, mast cells and platelets arrive. What do they dump into the area?
Histamine, bradykinin, prostaglandins, serotonin, a whole chemical cocktail.
And this cocktail leads to a key phenomenon at the periphery. What is it called?
Peripheral sensitization.
Explain that mechanism. What does the soup do to the nerve ending?
It basically marinates the nociceptor and lowers its activation threshold. So a stimulus that normally wouldn't be painful, like just light pressure, now causes the nerve to fire like crazy.
And this explains what clinical sign?
Primary hyperalgesia, the fact that the skin right around a cut is so exquisitely tender to touch.
Excellent. Now, there is one more specific type of nociceptor you should mention if you want to get the top marks. It's a bit more of an advanced concept.
Oh, the silent nociceptors.
Tell me about them.
They're like sleeping giants. These are receptors that, under normal conditions, are completely unresponsive to mechanical stimuli. They're just silent. But when that inflammatory soup hits them, they wake up. They get sensitized and start firing in response to stimuli they would have previously ignored. They essentially recruit more pain signals into the mix, making everything worse.
Excellent. Okay, so the signal has been generated at the free nerve ending. Now it has to travel. We're entering the transmission phase. This is the core anatomy of your answer. You must distinguish the first-order neurons.
A delta versus C fibers. This is a classic comparison table in all the textbooks.
So walk me through the A delta fibers first. Let's build that table.
Okay. A delta fibers. These are the first pain or fast pain fibers.
What do they look like? Myelinated or unmyelinated?
They are small, but they are myelinated, and that myelin is absolutely key.
Why?
It allows for saltatory conduction. The signal jumps between the nodes of Ranvier. It's fast.
How fast are we talking? Give me a number.
Around 6 to 30 meters per second. Some books say 5 to 30. It's quick.
And the sensation it produces.
Sharp, pricking, electric. It's very well localized. This is the ouch when you first stub your toe or get a pinprick.
And the primary neurotransmitter they release at the synapse.
Glutamate. It's a fast, excitatory amino acid. Quick on, quick off.
Perfect. Now contrast that with the C fibers.
The C fibers is the second pain, or slow pain. They are tiny, less than 1.5 micrometers in diameter, and critically, they are unmyelinated.
So no insulation.
It just crawls along the axon. The speed is something like 0.5 to 2 meters per second. That's basically walking pace.
Which perfectly explains that delay we all experience. You hit your thumb with a hammer, there's that immediate, sharp, shocking pain.
That's the A delta.
And then, about a second later, this deep, throbbing, burning, sickening ache starts to build.
And that's the C fiber kicking in. And their neurotransmitters are a bit different, too. They use glutamate, but they also co-release neuropeptides, most famously substance P.
Why does substance P matter? What's different about it being a peptide?
Well, it's a larger molecule, takes longer to be synthesized and released, and it hangs around in the synapse for longer because its breakdown is slower. It's not as clean as glutamate.
And what effect does that have on the sensation?
It creates that lingering, miserable, poorly localized quality of slow pain. It's not a sharp signal. It's more of a sustained state of misery.
Very well put. Okay, so now we need to follow the wire. These fibers, bundled in a peripheral nerve, travel to the spinal cord and enter via the dorsal root. Where do they go immediately upon entering the cord?
They enter the dorsal horn. But they don't just, plug in right away at the level they enter. They can travel up or down 1, 2, maybe even 3 segments in a little tract on the edge of the dorsal horn.
Well, what's it called?
Lissauer's tract.
A crucial anatomical detail. Don't forget it. Okay, after ascending or descending in Lissauer's tract, they finally synapse in the gray matter of the dorsal horn. You absolutely need to know your laminae of Rext.
Right. This is pure memorization, I know. The dorsal horn is layered like a cake with different layers for different functions.
So take me through the most important ones for pain. Where do the A delta fibers land?
The A delta fibers mainly terminate in lamina, the marginal layer, and also a bit deeper in lamina V.
And the C fibers?
The C fibers have their main destination in lamina 2.
And what's the famous name for lamina 2?
The Substantia gelatinosa.
Why is lamina the second so famous? Why do we care so much about it?
Because it's a huge processing and modulation center. It's not just a simple relay station. It's packed with inner neurons. It's where the gate control mechanism, which we'll get to, actually happens. It's like the border control for pain signals.
Exactly. Now, you mentioned lamina V. There's a very special type of neuron found there. What is it?
The wide dynamic range neurons, or WDR neurons. These are the real troublemakers in chronic pain.
Why do you call them troublemakers? What's so special about them?
Because they're not picky. They don't just listen to pain signals. They receive input from the nociceptive A delta and C fibers, but they also receive input from the completely non-painful, large A beta fibers that carry touch and pressure information.
And this convergence of different fiber types onto a single second-order neuron is the anatomical basis for
referred pain.
Explain the theory, the convergence projection theory. Use the classic example of a heart attack causing left arm pain.
Okay, so a WDR neuron in, say, the T1 to T4 segments of the spinal cord is receiving signals from 2 places. It's getting nociceptive input from the heart, which is ischemic, via visceral efferent fibers.
Right.
But it's also getting normal, everyday sensory input from the skin of the left arm and shoulder via somatic A-gata fibers. All these signals converge on the same WDR neuron.
So the neuron fires and sends a signal up to the brain. What does the brain do?
The signal travels up the spinothalamic tract to the thalamus and then the cortex. And the brain has to interpret this. It says, well, hang on, I get signals from the left arm all day, every day. It's a very well-mapped area. But I hardly ever hear from the heart.
So it makes a mistake.
It makes a projection error. It assumes that this intense, unusual signal must be coming from the location it knows best. So it projects the sensation of pain onto the left arm.
Perfect explanation. Okay, the first-order neuron has passed the baton to the second-order neuron in the dorsal horn. What is the very next thing that happens, which is absolutely vital for your diagram?
Decussation. The axon of the second-order neuron crosses the midline to the opposite side of the spinal cord.
And where does it cross?
Usually in the anterior commissure, just in front of the central canal.
If you draw a spinal cord cross-section in your exam and you don't show that fiber crossing over, you have failed basic neuroanatomy. It's a huge red flag.
Noted.
So after crossing to the contralateral side, where does the axon go?
It ascends towards the brain in the anterolateral system.
And we usually split this system into a few different tracts or pathways, don't we?
Yes. The big one is the spinothalamic tract. But we can think of it as having two parts, the Neospinothalamic and the Paleospinothalamic pathways.
Let's start with the Neospinothalamic tract. Is this the fast lane or the slow lane?
This is the A-delta fast lane, the new path. It's the lateral spinothalamic tract.
And where does it project to?
It goes pretty much directly to the thalamus, specifically to the ventral basal complex, which includes the VPL nucleus.
And what kind of information does this tract carry?
It's strictly business. It's the what, where, and how much of pain. It tells the cortex, location, left thumb, intensity, 8 out of 10, quality, sharp. It's for discrimination.
Good. Now, what about the paleospinothalamic pathway, the old pathway for C-fiber pain?
This one is more of a wanderer. It doesn't take a direct route. It sends off collateral branches to several places in the brainstem on its way up.
Like where? Give me a key one.
It projects heavily to the reticular formation.
And what is the clinical consequence of that projection?
Arousal. That's why chronic, dull pain is so exhausting and disruptive to sleep. The primitive part of your brain is constantly getting a signal that says, wake up, pay attention, something is wrong.
It also projects to the periaqueductal gray or PAG and the hypothalamus. What do those connections mediate?
The PAG is crucial for pain modulation, which we'll get to. But the connections to the hypothalamus and limbic system trigger the autonomic responses, the sweating, the nausea, the tachycardia, and also the emotional suffering, the affective component of pain.
So this slow pain pathway is less about where does it hurt and more about how much does this suck?
Exactly. It's the misery pathway.
Finally, the signal arrives at the thalamus. Now we're on the third-order neuron. Where does it take the signal from the thalamus?
It projects to the cerebral cortex, primarily to the somatosensory cortex, S1 and S2, in the postcentral gyrus. That's for the final, precise localization and discrimination.
And the emotional component.
That involves projections to other areas like the cingulate gyrus and the insula, parts of the limbic system. That's what attaches the feeling of unpleasantness to the sensation.
Okay. You have just described the entire ascending pathway from skin to cortex. If you stop writing your answer now, you get maybe 50%.
Right, because I've only described the input signal. I haven't talked about the volume control.
Exactly. You haven't discussed pain modulation. And this is a very high-yield section for us because this is where anesthetists live. This is where our drugs actually work. The brain is not a passive receiver of pain signals. It talks back.
This is the descending inhibitory pathway.
Correct. Trace it for me from top to bottom. Where does it start?
It starts in the midbrain, in a region of gray matter surrounding the cerebral aqueduct, the periaqueductal gray, or PAG.
And what activates the PAG?
It gets input from higher centers like the cortex and the hypothalamus. This is basically the brain realizing it needs to suppress incoming pain signals, for example, to deal with a more immediate threat in a fight-or-flight situation.
Okay, so the PAG is activated. Where does it send its signal?
The PAG talks to relay nuclei in the medulla. The most important one is the nucleus raffi-magnus, or NRM. There's also the locus coeruleus in the pons.
And from the nucleus raffi-magnus, where do the fibers go?
They send axons that travel down the spinal cord in the dorsolateral funiculus right back to where the whole story started.
Which is?
The dorsal horn. Specifically, they synapse on interneurons in the substantia gelatinosa.
And what do they do there?
They inhibit the transmission of the pain signal from the first-order neuron to the second-order neuron. They essentially shut the gate.
Now for the most important part. What is the chemical weaponry they use to do this? What are the neurotransmitters of the descending pathway?
This is the body's internal pharmacy. First and foremost, you have the endogenous opioids,
Wait.
enkephalins and endorphins. The PEG and the spinal interneurons are rich with them.
And how do opioids work at the synaptic level?
They work in two main ways. Presynaptically, they bind to the opioid receptors and block voltage-gated calcium channels. This means less calcium influx when the nerve fires, so less neurotransmitterless substance P and glutamate gets released.
And postsynaptically?
Postsynaptically, they open potassium channels. Potassium leaves the cell, which hyperpolarizes it, making it harder for the second-order neuron to fire. So it's a double whammy of inhibition.
Brilliant. What's the second major neurotransmitter from this pathway, from the nucleus or magnus specifically?
Serotonin or 5-HT.
And the third, coming from the locus coeruleus?
Norepinephrine or noradrenaline.
This is a key clinical correlation. Why do we, as anesthetists, sometimes add clonidine or dexmedetomidine to an epidural or use it as an adjunct?
Because they are alpha-2 agonists. They directly stimulate these descending noradrenergic inhibitory pathways at the alpha-2 receptors in the dorsal horn.
Yeah.
We are basically hacking the body's own pain inhibition system and turning it up to 11.
Precisely. You cannot finish a discussion on modulation without including the diagram and explanation for the gate control theory. Melzack and Wall, 1965, a landmark paper.
Okay, this is the scientific logic behind rubbing it better.
Explain it simply. Where is the gate?
The gate is a functional concept located in the Substantia gelatinosa of the dorsal horn. It involves an interaction between the pain fibers, the touch fibers, and an inhibitory interneuron.
Oh, on?
The small pain-carrying fibers, the C fibers, when they're active, they do two things. They stimulate the transmission neuron that sends the signal to the brain, but they also inhibit the inhibitory interneuron.
So they open the gate.
They open the gate. But the large myelinated A-beta fibers, the ones for touch, vibration, and pressure, they stimulate the transmission cell, but they strongly stimulate the inhibitory interneuron.
So what happens when the inhibitory interneuron is stimulated?
It releases an inhibitory neurotransmitter, probably GABA or an enkephalin, and it presynaptically inhibits both the C fiber and the A-beta fiber, reducing the signal getting to the transmission cell. It closes the gate.
So if you have both C fiber and A-beta fiber activity at the same time?
The A-beta fiber wins. Its stimulation of the inhibitory neuron is stronger than the C fiber's inhibition of it. So the net effect is inhibition. The gate closes, and less pain signal gets through to the brain.
And the clinical relevance is huge. Give me 3 examples.
1, rubbing a bumped shin. You are flooding the system with A-beta touch signals to close the gate on the C fiber pain signals. 2, 10-N's transcutaneous electrical nerve stimulation. It works by selectively stimulating those large A-beta fibers. 3, spinal cord stimulation for chronic pain. It's the same principle on a much more advanced scale.
Perfect. But now we have to talk about what happens when this entire system goes wrong. When modulation fails and the system becomes pathologically amplified, we have to talk about central sensitization.
This is the really terrifying part. This is how acute post-operative pain can morph into a chronic, debilitating disease.
It starts with a phenomenon called windup. Describe that.
Okay. Imagine one of those WDR neurons in the dorsal horn. If you keep hitting it with a repetitive high-frequency barrage of C-fiber signals like from an ongoing, untreated surgical incision, the neuron's response changes. It stops being a linear transmitter and becomes an amplifier. Each successive stimulus produces a bigger and bigger response.
And what is the molecular culprit, the single most important receptor you must mention when discussing central sensitization?
The NMDA receptor, N-methyl-D-aspartate receptor.
This is probably the most important receptor in all of chronic pain physiology. How does it work? Why doesn't it cause windup all the time?
Because under normal resting conditions, the channel of the NMDA receptor is physically blocked by a magnesium ion. It's like a plug in a drain. So even if glutamate binds to it, nothing happens.
What?
But if the neuron is subjected to that intense, sustained depolarization from the C-fiber barrage, the inside of the cell becomes positive enough to electrostatically repel and kick out that magnesium plug.
The plug is gone. What happens now?
Now the channel is open, Glutamate can activate it, and huge amounts of calcium flood into the second-order neuron.
And calcium is a powerful second messenger. It signals long-term changes inside the cell.
Exctly. It activates a cascade of enzymes, it changes gene transcription, it causes the neuron to put more excitatory receptors on its surface. The neuron becomes fundamentally hyperexcitable. It is now sensitized.
And the sensitization leads to two key clinical phenomena. You must define them.
The first is allodynia. This is pain caused by a stimulus that does not normally provoke pain, like the light touch of a bedsheet on a patient's neuropathic foot causing agony.
And the second? Secondary hyperalgesia. This is when the area of pain and tenderness spreads beyond the original site of injury. The receptive fields of the sensitized neurons have expanded.
In knowing this mechanism, what is the specific drug we can use to target it?
Ketamine.
Why?
Because ketamine is an NMDA receptor antagonist. It essentially puts the plug back in the hole non-competitively. That's why we use low-dose ketamine infusions for complex regional pain syndrome or to prevent chronic post-surgical pain. We are trying to prevent or reverse central sensitization.
Okay, fantastic. We have covered the entire physiology. Now, the final crucial section of your long answer must be clinical relevance and application. You need to show the examiner you're not just a physiologist, you're an anesthetist.
Oh.
And the key word here is a multimodal approach.
Right, which is just a fancy way of saying we're going to attack the pain pathway at multiple different points simultaneously. It's about mapping our drug chart to the diagram we just mentally drew.
Exactly. So let's do it. Go level by level. Let's start at the absolute beginning, transduction, at the site of injury. What can we do there? We want to stop the signal from even being generated, so we can reduce that inflammatory soup. We use NSAIDs, like diclofenac, to block prostaglandin synthesis. We can use antihistamines, and we can use local anesthetic infiltration right into the wound to stop the nociceptors from firing.
Good. Next level, transmission along the peripheral nerve and into the spinal cord.
This is the domain of regional anesthesia. We block the conduction of the signal. Peripheral nerve blocks, like a femoral or interscalum block, or neuraxial blocks, like epidurals and spinals.
And the mechanism.
We use local anesthetics to block voltage-gated sodium channels. If the action potential can't propagate along the axon, the signal can't move. The pain can't get to the spinal cord.
Next level, modulation at the level of the spinal cord and brainstem.
Here we want to boost the body's natural inhibition. We can use opioids, given spinally or systemically, to mimic our endogenous endorphins. We can use alpha-2 agonists like clonidine or dexmedetomidine to power up the descending noradrenergic pathway. And we can use NMDA antagonists like ketamine to block windup.
And finally, the highest level, perception in the cortex.
Here we want to modify the subjective experience of pain. The most profound way is with general anesthetics, which remove consciousness altogether. But we can also use anxiolytics like benzodiazepines to dampen the emotional response in the limbic system, or even things like paracetamol, which we now believe has a central mechanism of action.
Excellent. That is a complete, well-rounded answer. You've gone from the molecule at the periphery to the mind in the cortex. Before we wrap up, let's do a quick rapid-fire check on common Viva traps. Things students get wrong under pressure.
Okay, I'm ready. Hit me.
I ask you to differentiate the mechanism of action of 10NS versus ketamine. Both are used to treat pain. Both have an effect at the spinal cord.
Okay, 10ANS is based on the gate control theory. It works by stimulating large beta fibers to activate inhibitory interneurons in the Substantia gelatinosa. Ketamine is about preventing or reversing central sensitization. It works by blocking the NMDA receptor on the second-order neuron to prevent windup. They're completely different mechanisms.
Correct. Next question I ask you. Is there an objective measure of pain? I see the patient's heart rate is 120. Surely they are in severe pain.
No, absolutely not. Pain is, by its IASP definition, a subjective experience. Vital signs like heart rate and blood pressure can be signs of nociception, but they are not reliable measures of pain. The patient's self-report is the gold standard. There is no such thing as a painometer.
Good, safe answer. Finally, diagrams. You have 30 minutes for this question in the written paper. Which diagrams are non-negotiable? Which ones must you draw?
3 of them. First, the spinal cross-section pathway. It has to show the dorsal root ganglion, Lissauer's tract, the synapse in the dorsal horn, and crucially, the decussation to the contralateral-anterolateral tract. Second, the descending pathway. A simple schematic showing the midbrain peg talking to the medullary NRM, sending fibers down to inhibit the dorsal horn. The arrows have to point down.
And third?
Third, the gate control circuit. A simple wiring diagram showing the large A beta fiber and the small C fiber interacting with the inhibitory interneuron and the transmission cell.
If you produce that structure in your answer definition, classification, receptors, pathways with diagrams, modulation, and clinical application, you won't just pass. You will top the cohort.
It actually feels manageable when you break it down like that. It's a narrative. An injury happens, a signal travels, the spine processes it, the brain perceives it, and then the brain talks back.
That is exactly it. And you must remember, this isn't just academic knowledge for an exam. When you're standing in the recovery room at 3 a.m. with a patient who is in agony despite a load of morphine, you need this map in your head.
Right.
You need to be able to ask, what is the mechanism here? Is this uncontrolled transduction at the periphery? Is this central sensitization and windup? Is there a neuropathic component? Has their descending inhibition failed? That thought process is what guides your syringe.
Treat the mechanism, not just the symptom.
Precisely. Now go practice drawing those Rex Laminae until you can do it in your sleep.
Will do. Thanks for the grueling section, Professor. That was incredibly helpful.
Keep reading the primary texts.
And to our listeners, especially those of you prepping for exams, we hope this deep dive helps. Good luck. We'll see you on the next one.